My presentation will be on the transcatheter aortic valve replacement using the transfemoral approach. During this presentation, I'll be going over the introduction, heart structure overview, conditions impacting the aortic ventricle, TAVR, Edwards Sapien 3 prosthesis, 30-day outcomes in patients, conclusion, and my references. Heart valve replacement is an extremely common procedure, and according to the Texas Heart Institute, 106,000 procedures are performed in the U.S. each year. Open heart surgery is the most common way to repair valves, but it can be extremely problematic with many complications. These complications can include stroke, myocardial infarction, and serious bleeding. There's a strict criteria for patients to undergo open heart surgery, and patients that do not meet criteria have to consider other options. Open heart surgery can be a high-risk procedure for patients that are fragile, elderly, oxygen-dependent, and could suffer mortality. Transcatheter valve replacement via the transfemoral or transapical route is used on intermediate and high-risk patients. This approach is less invasive and lowers the risk of complications and mortality. To better understand this procedure, an overview of the structure and function of the heart is crucial. There are 4 different valves: the aortic, tricuspid, pulmonary, and mitral. The common function of all 4 is to provide unidirectional blood flow throughout the heart and blood vessels. You can think of the heart being separated into 4 different chambers. The aortic valve is located in the lower left chamber, and the main function of the aortic valve is to receive oxygenated blood from the left ventricle through the aortic valve, through the ascending aorta, and on to the rest of the body. The leaflets is the mobile part of the aortic valve. A normal valve consists of 3 leaflets made up of thin fibrous walls. In a normal valve, they open to allow blood flow during ventricular contraction and then close to prevent regurgitation. Healthy working leaflets allow for unidirectional blood flow. Bicuspid valves, the valves shown on the right, consist of 2 leaflets resulting from a congenital heart disease or calcification of the valve. Conditions impacting the aortic valve. The aortic valve is extremely susceptible to conditions such as stenosis and regurgitation. Stenosis is a condition where there is a narrowing of the aortic valve which prevents the valve from opening fully. The cause of stenosis is congenital heart defects, infection, and degenerative conditions such as aging that results in calcium buildup around the valve. Being born with a bicuspid valve is a birth defect. This degree score measures aortic stenosis in patients with normal left ventricular function. This means that they do not have conditions such as bicuspid valve. There are 4 different severity levels: mild, moderate, severe, and critical. The factors that are looked at is the valve area, measured in centimeters squared, the mean gradient, which is millimeters of mercury, velocity, measured in meters versus seconds, and indexed valve area, centimeters squared by meters squared. By using this grading score, they're able to calculate the measurement of the prosthesis that is needed to open up the damaged valve. Regurgitation is another condition that impacts the aortic valve. Regurgitation is leakage of the aortic valve each time the left ventricle relaxes. Leakage allows blood to flow backwards from the aorta back into the left ventricle with relaxation. This is not normal unidirectional blood flow, and to compensate for leakage of blood, the heart has to work harder and pump faster, which can result in heart failure. The photo on the left shows a closed valve, and on the right shows blood leaking through the closed valve going back the way it came. TAVR stands for transcatheter aortic valve replacement. This is the main and most effective therapy for valve conditions. The first human implantation was in a pig model in 1992, and the first successful human implantation was on April 16, 2002 on a 57-year-old male. 80,000 patients have been treated with TAVR using the transcatheter route, with new generations of the prosthesis being designed every couple of years. Like I've mentioned previously, TAVR is designed for patients who are at high risk for complications and death during open heart surgery, or they're unable to undergo general anesthesia because of restrictions such as oxygen dependency. Measurements such as the location and size of the prosthesis, inflation of balloon volume, size of the catheter, and many more are taken before the procedure. The degree score measurements mentioned previously are also carefully considered. A 2 and 3-dimensional transesophageal echocardiogram, labeled TEE, is performed at baseline, during, and after the procedure. The purpose of a TEE is to detect blood clots in the heart and gauges the severity of valve problems, infection, and congenital heart diseases. The results from this test and using the degree score criteria influences clinical decision-making for the specific patient's procedure plan. Using the transfemoral approach, the femoral artery is used as a delivery method for the new prosthesis. The patient is under local or conscious anesthesia and prepped for the OR. This is an animated TAVR procedure. A small incision is made to access the artery in the groin area. A sheath is then inserted through the femoral artery, which is guided up to the heart. This sheath allows the deflectable quadripolar balloon catheter to enter and be guided up to the aortic valve. With correct positioning, the balloon is inflated and opens up the narrowed calcified valve. The balloon is then deflated and pulled back through the sheath. With the new prosthesis attached, the balloon is sent back through the valve. Fluid fills up the new prosthesis, and it begins to expand to the exact size of the newly opened damaged valve. The balloon is then deflated once again and removed along with the sheath and catheter. With the new prosthesis in place, it begins to function immediately. This next section will go over the Edwards SAPIEN 3 prosthesis. The Edwards Life Sciences Company became a leader in the TAVR prosthesis developed in 1958 when Miles Edwards set out to build the first artificial heart. He decided to develop an artificial valve instead because there was more of a demand. The first prototypes were developed 2 years later. The Edwards SAPIEN, the Edwards SAPIEN XT, and the Edwards SAPIEN 3, which is the latest model, has been developed with this company. The prosthesis needs to be one of the highest quality, so it does not have to be repeated in such high-risk patients. There are 3 main components that make up the structure of the prosthesis, the first being geometric design. There are 4 rows of 4-columned cells, which provides increased strength of the valve. The second being the cobalt-chromium alloyed frame and the bovine pericardial tissue. These materials ensure fatigue resistance and radical strength needed for circulation. The bovine pericardial tissue is made from tough tissue sac that surrounds the heart of a cow. The tissue is what makes up the tri-leaflets that open and close during relaxation. The third component is the Carpenter-Edwards Thermafix outer skirt component that was designed to prevent paravalvular leak and regurgitation. The paper I focused on was 30-day outcomes in patients at intermediate risk for surgery from the SAPIEN 3 European approval trial. The objective of this study was to assess the safety and efficiency of the Edwards SAPIEN 3 prosthesis. 101 patients participated in this study, and there was a high exclusion criteria in order to participate. You could not have a myocardial infarction within 1 month before the procedure. You could not have a bicuspid valve, severe regurgitation, or an occurrence of stroke. Patients were sized with 20, 23, and 26 millimeter implants and prepped for surgery. The mean procedure duration was 69 minutes. There was a 98% success rate, and the success was defined as absence of procedural mortality, death, and correct positioning of only one valve in the proper anatomical location. The mortality rate of this procedure was 0. These are the 30-day outcomes, which was the most important data of this study. Some of the major outcomes examined were death with 1%. This was due to conditions other than the procedure. Myocardial infarction rate was 0. And the other important data set was the permanent pacemaker implantation with 4%. The placemaker outcome was the most important because the results showed a much lower number with this study using the Edward 3 than previous studies using the older model Edward XT. These are the results of this study. Having a 1% mortality rate represents the lowest ever reported. This suggests that the improved SAPIEN 3 may explain the lower rate. Like I mentioned previously, the patients that participated was at intermediate risk. This study mimics the results that were concluded from high-risk patients, which supports the idea of conducting this procedure on lower-risk patients instead of open heart surgery. The overall conclusion of this study was TAVR using the SAPIEN 3 in intermediate risk patients was conducted as a minimally invasive procedure and had a very high rate of technical success and a very low rate of mortality and complications. To wrap things up, the transcatheter aortic valve replacement has been performed worldwide and on thousands of patients. This procedure has limited complications and patient mortality when compared to traditional open heart surgery. TAVR benefits patients who are at high risk for surgery based on results from studies such as the one mentioned previously. This procedure can one day benefit patients with intermediate and low risks for mortality. For the future, TAVR using the transfemoral or transapical approaches could one day be the leading option for valve replacement.